Welcome everyone to today's webinar, Intravascular Robotics, Reshaping Vascular Intervention. Today's event is being presented by Hansen Medical, the global leader in intravascular robotics. Here is our agenda for today. We have two presenters. Dr. Bismuth will provide an introduction to intravascular robotics, and then Dr. Lumsden will describe the clinical experiences with intravascular robotics at Houston Methodist Hospital. Our first presenter is Dr. Jean Bismuth. Dr. Bismuth is a vascular surgeon and an assistant professor at the Methodist Debakey Heart and Vascular Center at the Houston Methodist Hospital in Houston, Texas. Dr. Bismuth and our second speaker, Dr. Lumsden, have been closely involved in the development of intravascular robotics technology from the beginning. Dr. Bismuth has focused his research interests on vascular surgery robotics as well as vascular surgery training and simulation development. He led and published the pivotal 20-patient first-in-man trial of the Magellan Robotic System that led to FDA 510(k) clearance in 2012, and he's currently a principal investigator on the ROVER Registry, which is a post-market, multi-center study of the first 500 cases being performed globally with the Magellan Robotic System. Thank you for joining us today, Dr. Bismuth, and I'll now turn it over to you.
Thank you, Brian, and thanks for tuning in and listening to this webinar, which is hopefully going to be informative for those of you who are interested in intravascular robotics. As Brian mentioned, we've been involved in this for some years now, about 5 to 6 years, and so I think we've determined what the need for robotics is along the way. One of the things we see in a lot of our cases is that they can be long, complex, and somewhat unpredictable. And we think that potentially the robotics have a way of making this a more predictable procedure. There are some discrepancies in training and skill sets. We see that when we train our residents and fellows. And so this could potentially bridge that gap. Physicians are, as we know, suffering radiation orthopedic injuries. And I'll go into the radiation bit just a little bit. And then complex cases, as you know, can be difficult, sometimes leading to complications that potentially could be avoided. If you look at radiation injuries, as you know, they're cumulative and they're permanent. And so when we start talking about more complex procedures, well, potentially if you can remove the whole component of driving to the site of interest, you could potentially also reduce the amount of radiation you're exposed to. And this is just an image from a publication 2009 looking at skin injury, and then again looking at the risk of fatal cancer, predicted fatal risk of cancer. If you look at the robotic system itself, we're talking about the Magellan Robotic System. There are two main components to the driving. One is the remote catheter manipulator, which has essentially two attachments for the two catheters, which I'll go in and explain a little bit more carefully in a second. And then it has the remote wire manipulator, which is on the back end, essentially consisting of two belts, which can drive the robot, pull it back, and also torque it. This is the physician workstation. Now, this is not the only component from which you can drive. There's also a pendant, which is at bedside, which allows you to do everything you see here except for the 3D controller. So primarily, I personally navigate with the buttons, but we do use the 3D controller as well. The foot pedal allows you to shift between the leader, which is the equivalent of your diagnostic catheter, and the sheath, which would be the equivalent of sheath you would use for any case. This is a video just going through the details of the mechanism. You saw there the workstation. Here's the RCM and the catheter being loaded onto it. You can then see from the workstation how you can control the guide wire, driving it and retracting it. Also here you can see how you could torque it. The two belts basically run over each other and can torque that wire very much like you would do with your own fingers or a torque device. Again, the same mechanism you can use with either the buttons for the leader, advancing that, and of course flexing it. And you can also, as you can see here, rotate it in a second right here. And that allows you, gives you actually 6 degrees of freedom, which can be very important when you're working in this somewhat complex three-dimensional space. Here you can see the 6 French catheter, which I'll describe in a second. That actually is a single catheter that has 2 bends, a proximal bend and a distal bend. essentially this allows you to see how the catheter can function in that three-dimensional space. If you look at this chart from Cook catheters, essentially you can create almost every catheter here with one single device, which allows you to cannulate many different targets with the same system, a clear advantage as far as I see it. If you look at the two catheters that are available in the Magellan family of robotic catheters, the first one we started using was the robotic catheter 9 French, which has essentially two telescoping systems, a robotic inner leader catheter and a robotic outer guide sheath or catheter. They can accommodate wires 014, 018, 035. This has primarily been used as far as our caseload for AAA or FEVARs and carotid stenting, iliac SFA disease. The Magellan 6 French system is probably gaining more momentum as far as embolization and lower extremity below knee procedures, and has those two bends as I mentioned in the previous video. If you take a little more detailed look at the 9 French system, it has full roll capability. It has a 6 French outer diameter for the inner leader catheter, and then accordingly has a 9 French outer diameter for the sheath. The leader can bend up to 180 degrees, 360 rotation, and the sheath can bend 90 degrees with 360 rotation. The 6 French system again can rotate 360 degrees, has less bend at the distal bend, which is 140, and the proximal bend 60. This is a case we did live, but this is really just to show you the SFA intervention. So normally, as you know, the wire, if you were to advance it without support, it would likely go into that terminal branch, that collateral. You can drive this with enough support through the occlusion, but you can also, as we did in this case, which I'm not going to show the video, but you can go subintimally. And the nice thing about this is you can angle the catheter, the leader catheter, towards the location you want to go towards, and again, re-enter by bending it the opposite way. This is kind of a depiction of the literature that we've amassed around the catheter. So there's some preclinical work, which I'll show briefly. That was really just safety data on animal work. Our first in men presentation, which was 20 cases Brian had mentioned in his introduction. Some carotid stenting potential benefits, FEVAR case reports, and we're going on to what we hope is going to be a good clinical caseload of the ROVER Registry. The Magellan in vivo animal study basically suggests that reduced vessel wall damage using the intravascular robotics was pretty significant, and also we may have improved catheter flexibility and range of motion, which is not surprising. If you look here, this depiction really shows very clearly how on your right-hand side, or rather your left-hand side, would be the manual catheterization. You see a significant amount of injuries, and there are major injuries which you see none of with the robotic catheterization. So at the very least, it's no worse than manual catheterization. If you look at the initial worldwide experience, which is now approaching 500 cases, this includes both cases done by interventional cardiologists, radiologists, as well as a large amount of vascular surgeons. Most of the cases are aortofemoral. There are some EVARs, FEVARs, but essentially we pretty much cover the gamut of treatments. I think the one thing that's a little bit different is our experience. We've done a number of venous cases treating subclavian, brachiocephalic, SVC, and iliac occlusions. But of course, as far as the arterial beds, we cover pretty much the entire vascular beds. We have found that there are some benefits to using 3D imaging, and Dr. Lumsden is going to go through some cases and show you this in more detail. But essentially, we do a lot of fusion imaging using cone beam CT. This allows us to use some markers that gives us reliable targets. But the stability of the robotic platform is really what takes it to the next step and allows us to treat with relative ease. This is essentially a depiction of the number of aortograms or angiograms we do in order to define a vessel before getting into it. When we combine the robotics and the 3D imaging, we are able to substantially reduce the number of angiograms we use, essentially in a lot of cases 80% of those with 0 to 1 angiogram or aortograms per case. And so we go straight for the cannulation of the vessel in question. You can see that depicted here where we're trying for an SMA, which had been failed on by one of my partners. He tried again in this case, again using the markers, so it's not just the markers. Here we are with the robotics. You can see the guide wire advancing, our leader and our sheath are at the top. And I think really the stability of the platform here, we're just advancing the leader, which goes in with relative ease into the SMA. That first ring shows the origin of the vessel, again here entering, and then we're going to advance the wire. But just to show how we combine those two platforms. As far as the learning curve, this is actually a slide from one of our partners here, Miguel Valderrabano, who is a electrophysiologist, using the different robotic system, the Sensei system, which also belongs to Hansen Medical. But his learning curve and that of a lot of the users for the Sensei system was around 20 to 30. And so, you know, they did need a little bit of time and got frustrated, but then eventually learned it and have been able to reduce their radiation times to about 5 minutes. We saw that in our first in man, that operator number 2 down the middle of that column is actually a cardiac surgeon who's never touched a wire or catheter in his life. And you can see he was able to do all the cases with significantly more time, but was able to do them. So I think the learning curve for the Magellan system is a lot lower than it is for the Sensei system. This is the first publication we're looking at from the ROVER Registry. This essentially combining retrospective data from Houston Methodist as well as the Miami Cardiac and Vascular Institute. And essentially what it shows, these are very much end-of-the-road cases we failed on, difficult cases, and our treatment success and target success are quite high at 91 and 92%. And you can see sort of the different vascular beds that we treated here. So I think that's pretty significant. And I think in conclusion, clinical value it really is enabling advanced endovascular procedures with more ease, less time potentially, provide a reliable and effective therapy delivery, and as we move on to sitting at the control station, reducing the radiation exposure. I think long term is going to be very important. The catheter roadmap, there are some catheters in development that are going to be larger, and they'll be able to deliver some of the other therapies such as fenestrated EVAR, aortic valves, and so on. And then there is a transport system which is pretty attractive as you could buy one system and move it from one interventional suite to another. Having said this, I'll then move back over to Brian, and we'll let Dr. Lumsden come in and give his presentation.
Our next presenter is Dr. Alan Lumsden. Dr. Lumsden is professor and chairman of the Department of Cardiovascular Surgery and the medical director of the Methodist Debakey Heart and Vascular Center at the Houston Methodist Hospital here in Houston, Texas. Dr. Lumsden is an internationally recognized leader in the field of endovascular surgery, and like Dr. Bismuth has been closely involved in the study of intravascular robotics technology. Dr. Lumsden has particular interest in studying and clinically applying the combination of intravascular robotics with advanced imaging technologies to improve predictability and reduce radiation doses in complex endovascular procedures. Thank you for joining us today, Dr. Lumsden, and I'll now turn it over to you.
Thank you, Brian. And again, let me welcome you to this very exciting seminar. What I'm going to do is talk through really just a variety of cases that cover a multitude of different clinical situations to try and give you an idea of the scope of procedures that can be done and to try and stimulate some of your thought processes for your own practice. Let me just disclose, first of all, we do have 2 conflicts. This is what we call our Advanced Imaging and Navigation Laboratory. This is a preclinical lab in which we're trying to integrate 3D imaging with Catheter Robotics, and we've had research support from both Siemens and Hansen Medical, our host today. So having said that, let me kind of go on and let you see what we're really talking about. This is our clinical operation, which is mimicked in our research lab. And what really is a fundamental game changer for us is the fact that we can now create a CAT scan, in the hybrid room. And that really is where we see how we optimize the use of catheter control is by interfacing it with 3D reconstruction in a multiplanar environment and as John kind of teased you with, showing you examples of how we integrate those concepts. And this will come up and be highlighted in a variety of different clinical scenarios. So here are some of the examples that we're going to actually go through. Obviously, by virtue of the time, we're going to have to go through these fairly rapidly, but it kind of gives you a sense of the scope of the procedures that we can take on, and we believe this platform will allow us to do many additional things in the future. So here's a case, and this is a case who had the patient had descending thoracic aneurysm, doesn't have a good seal zone by virtue of the taper, and the plan was to protect the celiac artery. There's an imported CT scan that we fused on top of the patient. And what you're looking at is the Hansen control setup, and what you're looking at here is it tells you how far the wire is advanced, it tells you the rotation and the bend on the leader catheter or diagnostic, and what the bend in the advancement is on the sheath. And so you can choose either to operate this table side, or you can operate it inside the control cockpit. And it really depends upon exactly which case we're doing. Sometimes you got to, as in this case, if you got multiple sheaths through the groin, you need somebody who's going to be controlling those sheaths. But here you can see the idea is that this is the gore sheath. We have a wire going up the aorta, and the plan is to actually catheterize the celiac artery, advance the sheath into the celiac artery, and just leave it there so that we can be fairly aggressive in our deployment system. And this can actually be catheterized, fairly easily from the groin using the Hansen system. And what is particularly appealing is the stability of it. Here you can see that it's been advanced out the splenic artery. This marker is on the end of the sheath. This is the leader catheter. So even in a tortuous artery such as the splenic, you can in fact navigate this out fairly distally into the splenic artery. And what was being done in this particular situation was actually to deploy, an aptus sheath. And to put the aptus sheath into, to deploy the staple into the bottom end of the endograft. And so all was very stable. Now, there's a patient of mine, and this patient was a fairly complex lady who I'd known for many years. She had occlusion of all of her supraortic trunks, so upper arm access was not an option. She had previously had stenting of her left renal, and she came back with malignant hypertension. And you can see the disease in her aorta, but had a complex renal artery stenosis. Now, the good news is I was going out of town, so I asked one of my partners to take care of this, and he's a very accomplished interventionalist and couldn't do it. Could get a wire in, but never could get a sheath over this and into the renal stent. So, I came back in town, was pretty confident I could do it, and once again spent about another 3 hours making exactly the same mistakes. We could wire it, we could never get a stable platform. And so we probably spent about 6 hours trying to do this. So at that point, we opted to bring in the robot. And this is our clinical hybrid room. This is the setup. The robot is attached to the bottom left of our the float table. And one of the things you will see is that there are some changes that you have to make in terms of your workflow. And I think this is an area that we're working with Hansen on to try and improve. You tend to move the image intensifier rather than the table. You do have to kind of work up in the air sometimes with the catheters and wires. And I think these are all very easily to improve things and will dramatically improve the workflow for the system such as this. So what we did was we did a 3D acquisition. You can see us setting up the rotation for the image intensifier. And again, this is our multiplanar, this is the single field on the workstation. And when you blow that up, you can actually see, why this is fairly complex, is there's heavy calcification in and around the origin of the renal artery and a fairly tortuous little flow pattern. So what we do is we mark the origin on the workstation, and we tend to draw that line, same line that John showed you, of a line which and shows you the trajectory of where you want to lay in your wire. And this that line is actually projected back onto the fluoro. So these images are fused together. That little round circle is the origin, and here's the direction we really want to get that wire. And so once again, we got the 9 French sheath, we got the catheter up here. And believe it or not, this was the first attempt at wiring this. And so you can imagine there were oohs and ahs. There were also a few oohs and ahs when this thing looped up in the renal artery, but at that point in time, we'd spent so long trying to get a wire in there that we weren't taking that out or trying to straighten it. So we closed our eyes, advanced the wire, And that allowed us then to go ahead and bring the sheath up into position, take the leader out, and then we went ahead and actually angioplasted it, and then we come in right after that with a stent. And so the nice thing is that it gives you tremendous stability once you get that sheath up into place. You can imagine we were fearful of losing that wire, but that's not going to happen in a situation such as this. So this was one of those cases, we all have those aha moments where we go, oh my gosh, we spent so long trying to do this manually, and to be able to convert this over and use it in the robot, why didn't we use this right off the bat? And that's a question that will come up again and again as regards how we actually use the robotics in our clinical practice. So let's kind of move on and look at more complex aortic interventions where we're putting in Snorkels and Chimneys. This is a patient who had previously placed endograft, and that is almost flush with one of the renal arteries. So on the workstation, again, this is how we plan those operations. We'll draw in those circles where we want to land the endograft. We'll draw in the origins of the visceral and renal vessels. And we'll draw in those center lines where we would like to see the wires. And you can choose to actually overlay all of these, or in this case, you can choose to overlay the one where we're kind of having trouble with. And in this case, it was a left renal, because we're having to come up and over the top of the endograft. And as you know, you can often do this with a reverse curve catheter, but you may or may not be able to get a sheath to track over the top of this device, because that can be particularly challenging. And so what we did in this situation was, once again, what you're going to see is the robot coming up here. So we have the three components. We're going to have the wire, the leader. The leader is barely outside the end of the sheath. And so have them advance up over the wire in traditional fashion. Now what we're going to do is bring that, we're going to bring the leader up. Typically we will bend that sheath away to give us some working room for the leader catheter, pull the wire back, put in the appropriate bend in the leader, and then catheterize that vessel. And we're not quite as fast as I'm going to show you here, but you can see essentially how this works. And we advance the wire, and the wire actually went up a branch. We kind of reoriented that, but you can see it is through the origins, just going off through one of these branch vessels, and we can reorient that with the catheter actually fairly easily. So this was something, again, we tend to choose the most difficult one that we're going to actually use the robot on. Now here's another example, and the title of this is Celiac embolization, and I put in there ipsilateral, contralateral. In this situation, let me just start this going, we were actually going contralateral, but you can do this very easily using the robot from an ipsilateral approach. As many of you know, sometimes that is very easy, sometimes it is almost impossible depending upon the calcification, angle of takeoff of the internal iliac artery. I would venture that in the overwhelming majority of them you can do it ipsilateral using the robot. And the way this is set up is those two circles of the origin of the iliacs. Again, this is all marked in the workstation before we start the case. And then what you're going to do is bring the leader up into position, pull the wire back, bend it, and then advance down the contralateral side. And you can see you get very similar motion that you would get with the manual catheter. And so one of the questions that often comes up is absence of tactile feedback. But you get exactly the same kind of visual feedback as you get when you're actually using a manual catheter. And here we're going to advance the diagnostic, the leader catheter up and over. You support it by bringing the sheath up, putting a little bend in it, and holding that in position. You can see it coming up fairly rapidly. And then we can reorient the leader, and we can then go ahead and the reason these marks are moving is because we are moving the image intensifier, and as soon as you step on fluoro, they will realign. So we're optimizing the angle for the embolization. Now we probably could have done this with the 6 French system, but going up and over, you do get a little bit more support using the sheath. But you can deliver embolic material, coils, embolics, PVA particles, things like that, fairly easily through both the 6 French and the leader, on the 9 French system. And this was a situation where we put coils into the internal iliac artery, and then went afterwards and placed an endograft in that patient. Well, here's another even more complex type situation. This is a patient where we're putting a bifurcated excluder in the right common iliac because there's a big aneurysm there. Now let me just stop that for a minute, because I want, just like diagnostic catheters, you can have issues or when you're pushing forward of losing purchase. And so what we did in this situation, what you're looking at is the diagnostic is heading up against the wall of the endograft, and it's backing out the sheath. Just exactly the same as you would see when you're doing this manually. So what we do is retract the entire system, take some of this curvature out of the sheath at the same time, and let the whole thing sit back on top of that bifurcation. And we've made this very challenging for ourselves because this is, the endograft is sitting proud of the bifurcation. So you've got to come up out of the origin of the left common and start working up and over the top of the endograft, and then catheterize, you know, that little limb that's down there. Now that's fairly challenging to do under any circumstances, but you'll see we can actually do it reasonably easily. We still had kind of one false pass there. Here we're pulling everything back into position, and then we're going to bump forward. So with these little buttons, you can actually bump this forward. If it looks like it's pulling the diagnostic back out of there, you can put a little bit more bend in it, and then you can just gradually advance and up and over the bifurcation. And you can see that at this point in time, we're over the bifurcation. We're going to catheterize the origin of the internal iliac artery. Now this giant device that you see in the background here, our nursing staff and our anesthesia staff are always very apt at marking off what we actually need to catheterize, because there's always something on the patient that is exactly where we want to be working, and I'm sure you probably all have kind of that experience. So this has got nothing to do with the procedure. This is a device that is on the patient and happens to show that we really need to go right through that contralateral limb and catheterize the gate. So always good to get a little help from our anesthesia colleagues when we're doing things like this. And here you can see the sheath up and over the bifurcation, and we can advance this down through that gate. And you can see this is not going to be easy because there's an aneurysm, there's a tight stenosis. I'm sure a lot of you are going, oh my gosh, they're going to put two devices through that stenosis. Yes, we actually did, and believe it or not, worked fairly well. But trying to get through this and then catheterize with not a lot of working room, you know, is not the easiest catheterization, you know, in the world. With the robot, we can actually do that fairly easily. Okay, and that's good. That's what it looks like once we got it catheterized. We then actually put a, you know, I believe it was a Viabon that we put in here, and we sandwich these up. You can see the Viabon here. We're going to put a 7-second device into this, and this, you know, allowed us to preserve the internal iliac on that particular patient. So we're always using this combination of 3D imaging, robotic navigation, and delivery system. Now here's something I wasn't sure was going to even be possible. This is a patient of John's actually, and it is a patient who had an endoleak and who was having a diagnostic angiogram to try and figure out where the endoleak was coming from. I'm going to go back one step because I want to show you. And what was done here was up and over with the bifurcation. Now, as those of you who've done all of this know, that is not an easy thing to do. And so what you're looking at here is the top of the sheath for the Magellan catheter is sitting there with the diagnostic over the top. You can hook the bifurcation, similar fashion, but it gives you the stability to advance both the wire and the diagnostic catheter down the other side. Sometimes you can get the sheath over, sometimes you can't, but you can clearly get the diagnostic fairly far down the opposite side to do selective angiograms, select hypogastric, for example, if you were trying to shoot the iliolumbars. And so that is one of the advantages of whether it's an aorta bifemoral bypass graft with a high bifurcation or an endograft. You can actually get up and over these in most cases. I wouldn't say all cases with the robotic catheter. So let's move out of the aorta for a minute. We've talked a little bit about visceral-vessel catheterization. We've talked about the some of the complex aortic catheterizations. This is a young man with an AVM. You're going to hear us talking a little bit in the background. We're injecting the what we're doing is injecting the renal, and you can see it actually flowing down through this. And on this side, you're going to hear some of this background noise, but what you're going to see here is the robotic catheter has been placed into the renal artery. With the diagnostic catheter, the robot was brought all the way up into that renal artery, and you can see that we're actually embolizing the renal using the robot, using this kind of dual catheter technique, because it allows you to work way out into the renal and to block off basically that AVM, and this is what it looks like. All right, so moving forward, we're going to go on to the lower extremity, and John kind of showed you a case, but this is a short occlusion. We could probably do this without the robot, but again, it allows you to get the stability that you need to actually cross through that bifurcation and actually re-enter without much trouble. And then you can do whatever your therapeutic intervention of choice is on these patients. We tend to use them mainly in ones where we failed from a manual standpoint before we actually go ahead and use the robot. But you can see it's crossing through pretty easily. We'll reorient the wire and advance it down the pulpitale and then cross using the robot. So fairly rapid, fairly straightforward. Now we can't always cross the lesions, and I don't want to give you the impression that the robot is miraculous. But here's a situation, where it's also a case of John's where he's trying to cross a superior vena cable occlusion, and again this had been failed multiple attempts. It looks like it's relatively short, but here you're using the robot brought up from the groin, trying to actually cross this. Now we did not manage to cross this, but we've used it in several others where it is extremely beneficial to be able to drive through these central venous occlusions. Unless you think we fail on them all, here's an example. Again, using carto mapping. Again, this is just part of our interest in 3D imaging. In a chronic subclavian vein occlusion, we can see the robot is being once again brought up from the groin, coming retrograde. The robot is being advanced. Ignore these catheters with the dots on them because that's part of the carto mapping system. And then the wire basically was advanced and then snared from the opposite side, and then it's just business as usual. At that point in time, you can go ahead and stent them. Now, staying on the venous side, one of the things that challenges occasionally is taking out inferior vena cable filters. And this is not a patient. This is actually from a Cook lab that we were doing in the complex inferior vena cable filter removal. And, we were very interested in the control that we have with the robot in order to be able to potentially add to taking these filters out. Now, this one's pretty straightforward because it's well centered, but the nice thing is that the end of the sheath is completely controllable. So even if this apex was over towards one side, we can certainly angle the snare towards the tip of the filter. And you'll see what we've done here is you've got a little bit of angle in it. We have our snare that we're trying to engage the tip of the hook. Here we've kind of engaged it. Now with a little bit of manual back pressure on the snare, you can just bump forward on the robot sheath and it very nicely will kind of collapse this down, pulls into the 9 French sheath, and then we pulled it out. So this is something that we're very interested in managing these complex inferior vena cava filter removal. At the moment, it's something that we are increasingly using preemptively rather than just try and fail, now recognizing the ones that are going to be challenging from a manual standpoint and preemptively bringing in the robot. I put that first bullet point up with a little bit of trepidation. John talked a little bit about the first-in-man cases in Slovenia, and we were not out there advocating that if you've never done endovascular procedures, you should grab the robot. But I don't think the learning curve for people who've done a lot of these procedures is that great, as evidenced by a cardiac surgeon in Slovenia who sat down, not having done many endovascular procedures, and really found it pretty easy to drive the robot. There is no question that there are advantages to the operator in terms of the amount of radiation and wearing lead. Does it decrease cath inventory? That's somewhat tongue-in-cheek. You can we talk about, I think the title for this was Shaping Intravascular Robotics. The shaping word was chosen very carefully because it does allow you to produce shapes of a variety of different catheters. But, there's not insignificant costs associated with the disposables, and I'm sure that'll come up in our conversation. So why do we do this? First of all, what we do on a daily basis is about controlling catheters. It's about stability to deliver therapies. It's about our pushability to move across occlusions. And fundamentally, it gives you a level of control that you can't get anywhere else. It also, when we combine it with 3D imaging, serves the promise of, can we do what we call off-the-wall navigation? Can we get complications, for example, going over the aortic arch when the catheters interface with the wall of the aorta? And using 3D imaging and catheter robotics, there is a possibility. I'm certainly not saying that it can be done at the moment, but can you navigate center line would be extremely, appealing for us to be able to do that. We also think that you're going to be able to build tools to put on the end of this that haven't even been thought of quite yet. So with that, we hope we've whet your appetite a little bit. These are a variety of cases really from our experience over the past 12 to 18 months. And I'm going to hand it back to Brian. Thank you very much for your attention.